Hi, I'm Dr. Jill Albritton, and I'm a dermatologist and a dermatopathologist, and I have a special interest in vulvar disease. I'm going to moderate today's session. Thanks for joining us. We're going to do our virtual coffee with the experts, cases from the Vulvar Clinic, how your pathologist can be your ally, excuse me. Today, we're going to discuss some interesting cases among us, and you're gonna see how clinical pathologic correlation and coordination between the pathologist and the clinician are really crucial in making diagnosis in vulvar disease. The ISSVD is thrilled to announce a trial of a groundbreaking AI translation platform, and the name of it is Wordly, and it will enhance our commitment to diversity and inclusion. We ask that if you speak a second language, you give this a try today and give us feedback at the end. This will allow us to determine if we can reach more people who may feel more comfortable listening in their native language rather than English. To encourage your participation, we'll have a short poll at the end of the webinar, and anyone who participates will be entered in a raffle for a prize. So remember, your feedback is valuable, and please help us with this. This webinar is part of our Road to Slovenia, which is our 27th World Congress and International Vulvovaginal Disease Update 2024. This is a live event which will be held in Slovenia from September 15th to 20th of 2024. Be sure to visit the website to register and join us. We have an amazing scientific program, some optional workshops, and also networking social at a castle. So what could be better? Without further ado, I'm going to introduce my colleagues. Dr. Jason Reuter is our pathologist tonight, and he has an interest in vulvovaginal disease and works closely with vulvologists to help them reach the correct diagnoses clinically. He is on the executive board of the ISSVD, and he's been the past treasurer of the North American chapter of the ISSVD. Dr. Kristen Stewart is a vulvologist and dermatologist that works in Florida. She has talked multiple times at the American Academy of Dermatology on vulvar disease, and she's a key member of the Women's Dermatology Society. And then last but not least is Dr. Libby Edwards, who really needs no introduction. She's a medical dermatologist and vulvologist. She's been the past president and the secretary general of the ISSVD, and she's the co-author of Genital Dermatology Atlas. She's mentored lots of us. She teaches a bunch. Everybody pretty much knows Libby for her teaching. And currently she practices in North Carolina.
Okay, here are just a few cases that I thought were helpful to discuss with the audience because of the clinical and pathological correlates of that. And I'm going to start with this first case, Libby. You can see it was the case we've talked about, initial CN. And I will start then with her clinical photo right here.
This is a 74-year-old woman that I have followed for many years with lichen sclerosis. And the last few times I've seen her, she has been clear, but she's continued to have dyspareunia. And when I saw her this day, she had these white stria, and she also had some deeper redness in the vestibule that looked almost erosive. You don't see it very well in this picture, but I believe you'll see it in the next one. And I was concerned that she had developed lichen planus as well. I have a lot of women with lichen sclerosis and lichen planus. Most of the time, it's lichen planus of the mouth and lichen sclerosis of the vulva. So I needed Jason's help. And when I do a biopsy and need his help, I always send a picture and I put an X or a circle where I do the biopsy. This is not, I believe this is not the picture that I sent for him, because I would have put an X where I did the biopsy. And I will also put on there left vestibule, left labium majus, something like that as well. But I think that the picture probably tells him best exactly where the site is and what I'm looking at. And I will try to tell him exactly what I'm looking for and what my differential diagnosis is. Mhm.
I will add, Libby, I do like the fact that you send in a photograph with the paper requisition. I know not all pathologists get paper requisitions. Sometimes they just get it electronically. That kind of helps the working flow of my laboratory to basically staple it with the requisition form that I'm going to get with the slide. And I think that's, more helpful than just say, see the photo in the EHR, although that is an option for some pathologists.
And it's fabulous to me that Jason will call me when he has a question or he wants clarification. It is fabulous to have that conversation and for him to send me back when there's not a diagnosis, which, this is not a lab test. It's a closer look. And sometimes there's not a diagnosis. He gives me a good description with a histologic differential.
Yes. Yeah. And I will say then, obviously, sometimes, for more publication quality or whatever, you'll send me electronic image, which is fine, but certainly having that image is great. And hey, I learned a lot about the clinical from the photo that you send me, and then sometimes I could say, hey, Libby, is that just like the light glimmering on there? And then you'll explain, no, that's kind of how it really looks in the patient, or no, that's kind of more of an artifact. And so I think for any pathologist who wants to learn more clinical, which I think is the whole key to vulvar pathology, is really encourage their clinicians to take those photos. So, that's a great point, Libby. I wanted to show, this was from the right side, and I wanted to show you the correlating histology. And, this one just kind of had kind of some wimpy changes, maybe a little bit of thickening of the stratum corneum, just a mild perivascular infiltrate. I would not call that really lichenoid too much, or at least I'd call a vague lichenoid, but I don't see hyalinization of the collagen. So this is one where, I just kind of had to be descriptive, as you know, from my report and not tell you, but I thought it was also great that you also biopsied and showed me the left side. So do you want to talk a little bit more about the left side? And is this the erosion the erythema you're kind of referring to?
Yes. I wasn't sure if it was an erosion or if it's an atrophic plaque, but it sure looked like it could be lichen planus there.
Gotcha. Okay. And then you also sent me, more of a high-powered photo. And then
that's terrible.
Well, even I can see, even a pathologist can see the kind of this whitish stria and then this erythematous background. But what's really neat, Libby, is correlating the path then from the left side is, lo and behold, unlike the right side, I start seeing this kind of hyalinized zone and actually not a bad lichenoid infiltrate. And then I kind of scoured around for some more clinical photos, some more histology. And this is kind of bent, I'm sorry, for the artifact to the audience. But wow, I can really see a great hyalinized zone and overline a lichenoid infiltrate. And that is really good for me. Now, sometimes I did it in this case, but sometimes I will do an elastin stain. And so what normally happens is elastic fibers, which are kind of more darker here, will normally keep branching in this sort of what they call a candelabrum. So it's sort of this infinite branching that usually goes up to the epithelium. Here it's kind of hitting this downgrowth. But here you see a zone where it's completely lost. And Libby, I find this helpful as a pathologist to know if that hyalinized zone is an artifact or not. Because when I see a lost elastic fibers, I feel much more confident in telling you that that is hyalinization, and that's supportive of lichen sclerosis. Now, occasionally, I'll, some people talk about doing a PAS stain, which highlights basement membrane thickening, but honestly, I only see that PAS basement membrane thickening when it's already conspicuous on the H&E. So I really don't do that stain as much. Now, earlier this week, you and I were talking about, if CD34 helps, and that's really more for, distinguishing morphia, because there's normally CD34 positive cells kind of in this lower part right here, where it's going to be normal anyway in lichen sclerosis, but it's gone in morphia. But I thought this was a really great case to show, because again, the clinical can suggest lichen planus, but I do think I have enough histological evidence to give you a diagnosis of lichen sclerosis.
Hey, Jason, can I ask you to go back to the H&E and show us how you know? I mean, I understand the elastic tissue stain, that you've lost elastic fibers in the homogenization, but can you point out for the non-histologist, like what's the homogenization and how you know without the elastic tissue stain?
Great question. And I'm going to kind of go to this biopsy or portion of the biopsy. Now, down here, if you could understand, it's a little bit pink, but you kind of see, I could say fenestrations or holes, and that's just normal space between collagen fibers. But up here, it becomes smudgy and almost like it's like pink glass, a glassy type of appearance is kind of how I think of hyalinization. And, again, see, comparing this right here, this fenestrate, this is definitely abnormal compared to something that's more normal and deep. And as we know, lichen sclerosis is a disease that chiefly affects the superficial part, the papillary dermis right here. And it obviously can expand, but you're going to see it most underneath the epidermis. Does that kind of make sense?
Yeah. And then I had a question, like, Libby, I saw those pictures of that patient and I think I'd be like, oh my, where am I going to biopsy? So how did you decide where to biopsy, and like, what were you thinking? Because there are a lot, there were a lot of different areas to biopsy.
I was looking for the most prominent areas of stria. Tonight, I would have chosen the edge of the erosion as one of my two places instead of the stria. I would have done a stria for one, and I would have done the edge of the erosion for the other.
So I assume you were doing the stria because you thought you'd get lichen planus on the stria?
Yes.
So good lichenoid change without homogenization. Okay.
Because she had in the past, she had classic lichen sclerosis. Let me see. I don't know if she had a biopsy diagnosis in the past or just classic clinical. Oh, she had a biopsy. Jason had read just lichen sclerosis with no ifs, ands, or buts in 2018.
And in the red plaque that, you said you couldn't really tell if it was an erosion, were you worried about DVEN or squamous cell at all in those areas, or you were pretty sure that was inflammatory?
On that day, I was pretty sure that was inflammatory.
Okay. Thank you.
And by the way, it went on to clear with twice daily halobetasol over the next 6 weeks.
Oh, wow.
Just going to forward this on. And then, Libby, it's kind of like when it rains, it pours. You had another case that I thought was interesting, the initials RM that we've discussed.
Yes.
And I'm going to pull up that clinical photo of this particular patient.
Now, this is a 78-year-old woman who has known lichen sclerosis. Let me see. I've just followed her since last August. Was she known? Let me see. No, she just had itching, burning, rawness, and pain for the past 11 years. And I saw her, and you can see from this picture that she has lost all of her architecture, and she's got some hypopigmentation and texture change or shininess on her anterior and lateral modified mucous membranes. And she has that red erosion on her right there that you're pointing out. And so I felt pretty strongly that she had lichen sclerosis, and I was worried about differentiated vulvar intraepithelial neoplasia. And I biopsied the edge of that erosion and sent you a picture and sent you a biopsy and said that I thought that she had lichen sclerosis and please rule out DVIN. And you said,
Right. Or the biopsy said, okay, so, here we have a little bit hyperkeratosis, that makes brain a little bit, whiteness clinically, scaly clinically. And I do see, some, I mean, it's not the world's greatest, but there are some hyalinizing changes. And certainly with that previous history, the patient was new to you. And so I didn't have any previous history, but I could certainly buy, background changes of lichen sclerosis. And then then I started thinking, okay, now here's where we're getting to the edge. So this epithelium is becoming thinner. There's this smudge, which is just debris from an ulcer. All these multilobulated neutrophils in there. And then the thing that did struck my eye is, Libby's worried about DVIN. I see a little bit of darkening of these nuclei. I would, wonder if they're abnormal. So, with your clinical suspicion, I went ahead and did an immunostain called P53. And to make a long story short, we all know that vulvar intraepithelial neoplasia is either caused by HPV, which will be P16 aberrantly expressed, or if it's associated with inflammatory dermatosis such as lichen sclerosis, a marker called P53 will be increased, and it marks the nucleus cell. So here we have just a little bit of increase where it's dark and mostly along the basal layer, but traveling up. So this was one, Libby, I kind of had to hedge with you because there certainly can be DVIN that's atrophic and can look kind of basaloid like this. But I guess I just didn't feel it had enough oomph to call it DVIN. So I kind of hedged and said, hey, I think we need to follow up and watch what's happening clinically. And what was the result of that?
she was really, really miserable. And so I did something I don't usually do. And the same day that I biopsied her, I also put on topical anesthesia and I injected her with intralesional triamcinolone. A week later, I had her start a super potent topical steroid. And 6 weeks later, she was basically asymptomatic.
Wow.
And looked way better. And she's gone on to just about clear.
And
Wow.
so, Libby, that lesion was gone, and I assume if it wasn't, you would have rebiopsied it?
Oh, yeah, the erosion was completely gone when she came back.
Wow. So there you go. Sometimes, again, I've got a borderline stain result and some borderline histology, and I think that's very much a learning experience to, hear what happened to the patient. So,
Jason, I'm wondering if you had a different clinical scenario where, it was an older woman who had poorly treated LS, and this was more of a treatment-resistant plaque, if your recommendations would have been a little bit different since this P53's increased.
Yeah, no, that's a good question. I think I would again, really heavily rely on the clinical, and that's the great thing about getting that information, is like you said, is this a plaque that's resistant to therapy? And I think I would have pushed this up to some, I still don't think it's diagnostic of DVIN, but certainly, something that if there's a well-formed mass to please go back and to re-excise it.
Yeah, so the size of the lesion makes a big difference in your pathological.
Yes, yes.
And often we don't get size, or at least I
Right.
don't. I don't know about you.
Right. And then the history, is it recalcitrant to therapy or not? And certainly, having that, resolution was very good. Was
Yeah.
very reassuring.
And I have to say, I've seen a number of these cases with LS and the P53 slightly increased. And it's always concerning, although it's sub-threshold, but certainly you need the clinical correlation.
Yeah, I would agree. Yeah.
Libby, do you mind me asking, before you do the intralesional catalog, what are you using for topical numbing? I know it can be so uncomfortable. Sometimes I feel like I'm able to get people numb, and other times it's still very uncomfortable for them.
I'm using 6% tetracaine mixed with 6% lidocaine that one of the cosmetic dermatologists in town taught me about.
Okay.
When I have for a nanosecond, I used the topical anesthetic that the dentist uses, which is fabulous, but I have also blistered people with that, so I don't do that anymore. However, it was very nice. It also cleared their lichen sclerosis for a short while. We know that anything that you do that removes the epithelium for lichen sclerosis will clear it for a little while, whether it's ablative CO2 laser or liquid nitrogen or focused ultrasound or PDT. Well, so will alcohol-based topical anesthesia, but it does not give you a very happy patient.
Hey, Libby, so how long does it take to work? And do you ever give people topical lidocaine, that we send home with them? Do you ever have them apply it before they come in?
I do. And I even have some of my vulvodynia patients use it at home for pain.
Okay.
It stings for about 90 seconds, but it's worth it to people. Now, I do not put it on people who have an erosion or, macerated skin. The burning with that is not worth it.
Okay.
But for biopsies and for intralesional on the kind of skin that you've seen here, it's really nice and worth it. Over the past 5 years, I have had 2 people who've blistered, but I use it 4 or 5 times a day.
Thank you.
Mm-hmm. And I think I sent you an after picture of this woman, Jason.
Oh, yeah, I believe.
Yep.
Yes,
Mm-hmm.
I am so sorry.
There she is. Yeah, this is her after picture.
Wow.
I think about 6 weeks later.
Yes. Thank you for reminding me.
I love intralesional steroids. Love intralesional steroids.
What a difference. Wow.
Mm-hmm. Whoever invented corticosteroids is going to heaven.
Yeah, for sure. Okay, then I was going to transition to another interesting patient that we had, kind of almost in the same ilk. And that was patient initials JC. And just wanted to start with this clinical photo here.
Mm-hmm. Yeah, this lady I saw for the first time last May, the end of May. And she came to me with a presumed diagnosis of vulvar eczema. She had a greater than 10-year history of itching, burning, blistering, bleeding, cracking, rawness, and was really miserable. And I thought she had a pretty scary vulva. On exam, when you could look at her and really separate her skin, she had partial resorption of her labia minora, all of this puffiness, and she had advanced clitoral phimosis. You could not you could not see her clitoris underneath all of that. And it wasn't just from the edema. She had scarred over her clitoris. So I felt that she had lichen sclerosis, and I was really worried that she had DVIN and might have squamous cell carcinoma. So I enlisted Jason's help and sent a punch biopsy to him. One from the perineum. We don't have a good picture of the perineum, do we? And then one from the left medial labium majus with, yeah,
Sure.
really, you know.
Oh, so this was that, I believe this was the left medial labium majus, but this really caught my eye. I mean, I think the audience could, you know, understand for some of the previous photos, you know, the normal thickness of the epidermis, which probably is only like this much, but then it's way up here. And so we've got a lot of pallor here and a lot of at the top and a lot of eosinophilia, I mean, pinker than normal. And that sort of starts putting me on a high alert that this is an abnormal squamous proliferation. And up in the very top of the lesion, we see a lot of perikeratosis. And again, the very top of the intact cells, they're very pale. This is a sign of some abnormal maturation. But then when you look at the bottom of it, again, I think the audience can even appreciate that there's some very dark cells that stand out, even though this is sort of a modest power, that this is really concerning for something. However, I ended up doing immunohistochemistry and on this, and I did one marker. Again, I mentioned it for HSIL, which was P16. That was negative. And then I also did P53. I'm sorry I didn't have the photo with me, but that actually was negative as well. So I certainly couldn't call it DVIN Libby based on, you know, even though there's a little abnormality here, you know, without a good supported P53, you know, I kind of turned to what I kind of call hedge categories here. And there's various names for this. I know one common term is vulvar aberrant maturation. And there's also, you know, various terms such as DEVIL, differentiated endophytic vulvar intraepithelial lesion, vulvar acanthosis with altered, with architectural disorder or VAD. And recently, some people have named this as sort of a HPV independent P53 wild type vulvar intraepithelial neoplasia, or vulvar, vulvar acanthosis with vulvar acanthotic vulvar intraepithelial neoplasia, kind of a tongue twister, in a recent article in Modern Pathology. But again, it's just not quite the sufficient to call it DVIN. And there was a little bit of hyalinization here. You know, certainly that could suggest background lichen sclerosis, although it's not diagnostic. But then I think you ended up with a follow-up here, and here's the follow-up photo that I.
But before this follow-up, I also, with that first visit, because it was so thick, I was afraid that a steroid wouldn't get in it well. I injected her with 4 cc's of triamcinolone, 10 milligrams per cc. And she really looked quite good. That was in May. And in August, she looked quite good. But then she turned into that red picture that you saw.
Okay.
Which is still way better than it was.
Right.
And so I rebiopsied her then.
Okay. And then
because she was getting worse and itchy.
So increased itchiness, but at least she didn't have that thick edematous plaque anymore, which responded well. And so here's the correlation.
Now she's clinically looking like psoriasis.
Yeah, interesting you say that. So correlating histology, here's some psoriasiform change, but for the benefit of the audience, there is kind of edema here. We call this spongiosis. Actually, here's a large collection of Langerhans cells in the superficial epidermis. Contrast that to psoriasis, which usually would have collections of neutrophils in here. This actually was better for something like maybe a subacute allergic contact dermatitis, but certainly no concerning histological features to suggest, either, especially not DVIN, but nothing to suggest lichen sclerosis either.
So, Jason, what do you mean for the clinicians when you say psoriasiform?
Okay, great question. So, again, I probably have to go back a couple of photos, but again, the normal thickness of the epidermis is probably about this much, and there's some what we call reedy ridges, but they're usually not this long. These are very long, and they, that is not, it's called psoriasiform because it can mimic psoriasis, but it certainly is not diagnostic of psoriasis, but has some features of psoriasis, so we call it psoriasiform. Good question.
And then, it seems to me when I'm reading specimens that oftentimes if it's not textbook psoriasis clinically or textbook eczema clinically, if it's on the genitals or the palms and soles, then it's not textbook histologically either. So is that your experience?
Yeah, that is a good point, especially in the genital area. Psoriasis definitely can have very protean features, and I always try to give that as a caveat when people are asking about if it could be genital psoriasis. But to me, this just has so much spongiosis, and again, these collections of Langerhans cells tells me it's a slightly different immunological reaction. Again, this reaction that tends to go with allergic contact dermatitis. And so, could it be psoriasis? I guess it's not improbable, but I certainly don't favor it.
Mm-hmm.
And I guess that brings us to our last case, Kristen, which I thought was very interesting. We put the whole picture together. So this was patient LJ, and I will start with a clinical photo. And this was actually a couple of years ago.
So I'm sorry that this photo is a little bit blurry. I met this patient in 2021, which is when this photo was taken. But her story really starts, or her timeline, in 2016 when she had symptoms of itch and irritation and a vulvar nodule that was biopsied that showed squamous cell. She had a radical left vulvectomy and bilateral lymphadenectomy. All the lymph nodes were negative, but that shows you in this photo the distortion of the anatomy, and you can certainly see background changes consistent with lichen sclerosis. So I think in the next photo I have, it was taken the same day. Or maybe
I'm sorry, I just had included the one.
Okay.
Unless, let me actually, this was
that was a year later.
That was, I'm sorry, I did not have.
That's okay. I just had, where I biopsied was at the edge of the left labium majus, at the edge of the erosive plaque. That's a little bit more posterior there. But overall, there was a 15 millimeter firm, tender red plaque on this background of lichen sclerosis and scarring from her previous surgeries. And I sent that, and I think you have a picture of the pathology.
I do. And if the audience was quick, they would have realized I kind of gave some of it away. But so here we have infiltrating nests of atypical keratinocytes, and just higher power, this histology. So this is invasive cancer. And, I think the other thing to note about it is, I guess I would kind of call it a moderate degree of differentiation, meaning I don't see a lot of keratin production. Maybe here, there's a little bit of pink keratin, but for the most part, it's certainly not poorly differentiated, but it's sort of a moderate differentiation. And as anybody who's biopsied enough cancers knows that that's part of the pathology report is mentioning degree of differentiation. So, and I'm sorry I didn't have that second photo, but then this was, I believe.
This was a year later. So right after I did that biopsy and got that pathology that you just talked about, I sent her to GYN Oncology, and they did an additional left posterior radical vulvectomy. She did not, they had her stop her clobetasol postoperatively, and it took her a little while to get back in with me. But between then, for the 6 months before this photo, she was treating with clobetasol twice daily, and I was doing interlesional Kenalog also every 8 weeks. And still you can see that background lichen sclerosis is not, it's a little bit better, but not really greatly controlled. And there's this plaque. And she kept saying that the surgeons just felt like this was from healing. It wasn't, it was from the procedure, and this spot just wasn't healing. So that blue mark is where I did the biopsy. I was trying to get kind of a half of the edge and half of the red plaque. But and again, this is in 2022, but this pathology, actually, I think I was more on the plaque. And in retrospect, I should have gotten a little bit more into that red plaque, but it only showed lichen sclerosis and there was no malignancy. So I continued to treat her with clobetasol twice a day, interlesional Kenalog. I encouraged her to try either acitretin or methotrexate, but she was not interested in doing that, just trying to get the lichen sclerosis under control. And then another year later, I think is the next photo that we have.
Yes.
And in this picture, you can see where I'm biopsying again. I'm on the edge, but this plaque is still there. When I measured it in 2022 in that photo, I'm sorry, back in 2021, it's 15 millimeters, and now it's 25. So again, I clinically, just for other people, I wish I had done a bigger biopsy, and I wish I had gotten more of the red erosive plaque in my biopsy specimen as a learning point. One other thing before I talk about this one, down lower, you can see a little bit of a healing spot here. This is a case where she had come to see me the week before. I did a punch biopsy in that same location, and the biopsy specimen got to Jason and it was empty. And Jason texted me a picture of it. This is where I love knowing your pathologist too and trusting them. And he did everything he looked in the cap. He looked to make sure it wasn't squished, you know what I mean? And looked all over. If you're a dermatologist who does lots of biopsies and you haven't had this happen to you, I'm happy for you. And I hope that it never does. I think most of us have experienced it. And I'm sure on the other end, the pathologist has with that phone call too. I'll just like to say from my point of view is that I do kind of two things. One, I disclose to the patient and I call them and say the specimen bottle got there and there was nothing there for them to process. I'd really like to do another biopsy. And sometimes that can be hard to convince somebody to do and to have that trust and have that relationship. But I really think disclosure and being truthful works every time I've ever needed it. So she's coming back now a week later. The other thing I did was I went through the process improvement. I went into the room. We looked everywhere. I was with one of my most senior medical assistants, and we went through like, where did we go wrong? One of our rules is nothing goes in an unlabeled container ever. Everything has to have a label. If there's more than one biopsy, only one cap is off at a time. The cap goes on, the new one opens, and having those processes can help. And despite my processes, I actually don't know still how we did not get the specimen in the bottle on this one. So in any case, she comes back a week later and we do this additional biopsy. And then Jason has that interesting path, I think, at the next slide.
Okay, so what I thought was interesting is, see if I had a lower power. This is actually normal. So this, again, for the audience, they could recalibrate their eye to normal and normal thickness and everything else, and normal, cellularity of the epithelium. But what caught my eye is at the edge. We know it's the edge because the ink is on top of it. Is again, we see a lot of dark cells that are full thickness of the epidermis. And so again, that's my radar for something bad. Now, when we talked about VIN, the type of VIN, which usually has the full thickness immature cells that are very blue, tends to be HSIL, so related to HPV. So I actually, and then here's just higher power. Again, these cells are going all the way up to the top, and they just don't look good. They look abnormal. But I did a stain called P16, and just I didn't show the previous one, but here's that epithelium, and there's just some kind of spotty positivity. Sometimes your pathologist will call this like a checkerboard pattern if there's kind of alternating here. But really, to be positive for HSIL has to be in a large block, contiguous cells, at least in the lower 1/3. And the counter stain is kind of light blue, so the audience can kind of appreciate here's where the epithelium is right here, and this would be the subepithelium. But then I did the stain that I referred to earlier, and we've talked about, is the P53. And so what was interesting is, again, this is full thickness expression of P53. And so it's an unusual P53. We tend to call this basaloid P53 because it really does look like HSIL. Again, if there are any pathologists in the audience, they would know that, this could almost pass for HSIL, whereas the case of VAM would be more classical differentiated VIN because of its pinkness. But it's a great mimicker, and a reason pathologists sometimes should do both the P16 and the P53 when they're worried about VIN to help cinch the diagnosis. Sort of the other fun part about this is, if you can appreciate, here's actually the basal layer, where most right here, which is actually negative, and most of the time it's mostly positive in the basal layer, but hardly positive up here. So it's just sort of an unusual entity and variant of differentiated VIN, which is actually kind of immature looking rather than mature or differentiated looking. And so I thought this was really fun from the histology of it. So thank you for sending that interesting specimen, Kristen, or else I wouldn't have a case of basaloid even to show people.
Well, it took me 2 tries to get it to you, but I'm not the patient too.
Persistence pays off.
Right. In January of this year, this was those 2 biopsies were done in November. She had another left posterior partial vulvectomy, and the final path showed squamous cell carcinoma in situ. Immunostains were negative for HPV, but the margins were still positive from 6 o'clock to 12 o'clock. And the oncologist gave her the option to wait 3 months and rebiopsy and consider CO2 laser or repeat excision. And she chose to wait. So I'll continue to follow her and treat to the best of my ability the background lichen sclerosis and see how she does.
Excellent. Well, yeah, thank you guys for showing those patients and having the photos and being able to correlate the histology.
It's great cases, very interesting.
So we have some questions in the chat, guys, that I can pose to y'all. So somebody wants to know, could you share the doses and criterion for intralesional steroids, Libby?
I use the triamcinolone acetonide, and I'm only really aware of the Kenalog brand existing. 10 milligrams per cc most of the time. If I have a very hyperkeratotic lesion, I will occasionally use 40 milligrams per cc. And how much I use depends on the area to be injected. It's about 0.1 cc's per square centimeter. What
Thank you.
about the other dermatologist here? What do you guys use?
I also use 10 milligrams per cc. I'm wondering if I could use more, hearing that you've used up to the 4 mLs. I'm usually using about 1, but for larger areas, I'm going to definitely be increasing that volume a little bit, just hearing your experience.
So there's another question asking for your technique with intralesional steroids. Do you have a particular technique?
I'm not sure how to answer that. I use, depending on, once again, the size of the area, because I have an occasional patient, these poor ladies that end up in assisted living or in retirement areas, and they can't see their skin. They have some cognitive difficulty in applying their medications, and their caregivers will not apply their medication. I'm having them come in about every 6 weeks, and I'm injecting their lichen sclerosus for them, and I'm injecting large areas. I'm using a 1-inch 30 gauge needle and injecting large areas, and I'm injecting up to 3 cc's of medication. I'm in.
Are you doing that dermally? I mean, dermally rather than sub-Q, I guess.
Yes, I'm trying to get it dermally, almost as though I'm doing PPD. I'm doing it just under the epidermis, and going in a line, almost linearly, to inject a large area. I can inject most of the vulva and perianal area with 3 cc's.
This person also would like to know, is your 7% tetracaine lidocaine a gel, cream, ointment, or liquid?
It's 6% tetracaine, 6% lidocaine, and it's in an ointment base.
Thank you. And then someone else would like to know, what are the conditions, the clinical conditions associated with psoriasiform changes? Jason, maybe that's a good one for you.
Yeah, that's a really great question. So in the vulva, the 2 chief differential diagnoses would be, again, psoriasis and a subacute spongiotic dermatitis, which in the vulva is chiefly going to be things like, contact dermatitis or just eczema / atopic dermatitis. Now, there are other things that can cause a psoriasiform change, but they're going to be zebras, okay? Stuff like, vitamin deficiencies, things that we wouldn't expect to see limited to the vulva. But again, psoriasis and a subacute spongiotic dermatitis.
And then the next question is, how do the clinicians decide whether to use IM or I intralesional Kenalog?
I can start
Clayton,
or
would you
say my
stop,
point of
please?
view. Sometimes it's
Hush.
very difficult for patients to tolerate the intralesional Kenalog. It certainly is the first choice from a safety standpoint to keep it localized. And Libby's, and we've already talked about the numbing beforehand, can be very, very helpful and very effective to make it tolerable. But I'll use intramuscular Kenalog for patients who aren't able to tolerate it. And sometimes do that. And it's also difficult if somebody's heavy for intramuscular Kenalog, because if I feel like I can't get the Kenalog into the muscle of the backside, I don't think it's all that effective and puts you at risk for complications.
Did you want to add anything to that, Libby, about when you use intramuscular versus intralesional Kenalog, or is that pretty much your practice too?
That's pretty much my practice too. I use much more intralesional on the vulva. If I have somebody who has extragenital disease also, I'm more likely to use uh, intramuscular. And when it's lichen simplex, I'm starting to use quite a few of the biologics as well.
Mhm.
Regarding the intramuscular catalog, actually, one of my colleagues here in Jacksonville, Dr. Doug Robbins, if you do Doug Robbins intramuscular catalog in Google, you'll get his paper, or intramuscular catalog, yeah, and it's a good review of how to do the injection and the conditions that IMK is useful for.
Oh, that's great. Have y'all ever used anti-malarial if the person has extragenital LS too?
I don't think I
In
have.
the, yeah, it's in the literature, all these incidental case reports. Okay.
I go on.
No, go right ahead, Libby.
I used more of the systemic medications earlier in my career than I do now. I was not very impressed. Almost the only systemic that I use now is methotrexate. And I'm
Okay.
not terribly impressed with that.
Wh-
What
Um,
about you?
what, I have a patient who has extragenital and genital LS, and she had laser at an outside derm, and I don't know if it's a coincidence that when we started the hydroxychloroquine, the extragenital stuff got better, or if it's actually that, but it's such a low risk medication. She stayed on it. Of course, that's not that's not her primary treatment for her genital disease.
Well, I'll try it because I have terrible luck with extragenital lichen
Art,
sclerosis.
yeah.
Yeah, I was having trouble getting it under control.
Mm-hmm.
So. Jason, someone wants to know, have you ever seen this P53 pattern in Paget's disease?
I have not seen that pattern in Paget disease. Certainly, the morphology should be different in Paget disease. We're going to get individual cells, and they're actually be of glandular origin. So they're going to have, kind of foamy cytoplasm. They're going to stain with things like cytokeratin 7 and CEA. I certainly haven't done a literature search. I mean, it could be a marker that is aberrantly expressed in that, but it's just I don't have a lot of data or experience on that.
Yeah, neither do I. Um, so another question, this is a two-part question. For case two, how about the diabetes influence on LS? So do you think that the patient's diabetes influenced their LS, Libby?
I'm not remembering which one was case two, but I've been unimpressed with diabetes influencing lichen sclerosis, except if they're getting candidiasis with the Kebner phenomenon with that. Um, what do the two of you think?
They can kind of run together being autoimmune conditions, but of course, not everybody with LS has diabetes and back and forth. But I think the hard part is people with diabetes, and you add the disrupted barrier of the lichen sclerosis, and you add a topical steroid, you increase that risk of candidiasis, and that can sometimes be difficult, especially depending on what their topicals. Sometimes some of the specific diabetes medicines, I think, predispose them to candidiasis more. So now you have lichen sclerosis complicated by candidiasis. In those patients, I'll tend to try tacrolimus instead of a topical steroid because I think you get a little bit less candidiasis. I'm not even totally convinced of that myself, but I think there's a little bit less. And I'll also do a lot of kind of prophylactic topical anti-yeast treatments if they tend to get a lot of yeast, and I'm still trying to treat their lichen sclerosis topically.
Yeah, I
Well,
do
now they're saying that there is
too.
a correlation between diabetes and the metabolic syndrome with lichen sclerosis with some of the newer things, but I haven't noticed diabetes being associated with worse lichen sclerosis, although these new medications for diabetes are evil. And I'm having a terrible time controlling the candidiasis in some of these women who were on these medications that control blood sugar by having them urinated out.
Mhm.
Yeah. I don't know about y'all. So I only have certain patients, of course, that have they get recurrent candida, and I've never noticed the correlation to diabetes, but I have a couple of patients that get recurrent erythrasma after they started clobetasol for LS. And this patient actually says that the erythrasma is worse than the LS. I mean, we have it under control, but it's a continuous treatment. The second part to that question was they wanted to know it says fractional laser is effective here. What's your opinion?
This is so controversial. I kind of hate to say it unless I have a bodyguard, but I'm kind of a fan. I looked at 11 patients who had recalcitrant lichen sclerosis, despite twice daily, many months of a super potent steroid plus intralesionals. And most of those patients had also been treated with methotrexate, and they did very, very well with fractional CO2 laser. One had no change. The others either cleared or almost cleared and were asymptomatic. We put a super potent topical steroid on immediately after their laser, but they had also already failed intralesional steroids. Now, some of them quit using their topical steroid because they were convinced that they were cured, even though I told them to keep using it, but it worked very well on them.
Thanks. I think we're going to end it there because it's past 10:55. Remember, guys, if you use the Wordly app, we'd really like you to fill out the survey so we know how well it translated. And please remember to visit the isvd.org site. Consider joining us for the World Congress and the International Vulvovaginal Disease Update this September in Slovenia. If you have any questions about joining the ISSVD or educational tools, you can email us at isvd@issvd.org. And you can also look at the event tab to see more about the events in Slovenia. And thanks so much for our panelists, Dr. Reuter, Dr. Stewart, and Dr. Edwards. I enjoyed listening to the discussion.
Thank you.
Thank you.
Thank you, everybody.